Thank you so much, Dr. Preeti, for that very kind introduction. And at the same time, I'd also like to thank the organizers of RSSDI 2021 for having me here today. And over the next, say, 20 minutes or so, I shall take you through this topic of how to curb appetite in people with diabetes. And as rightly mentioned by Dr. Preeti, this is often a very important clinical challenge, but I would say it's a very important player in the management of the dietary management of diabetes in our country. I think all of us in the audience are well aware, and we know that diabetes has reached pandemic proportions globally, especially in the South Asian region, where we do have a lot of diabetes. We lead along with China with the world's largest number of people with diabetes in the world. But with diabetes, what we also get sometimes is obesity. It's often a dual pandemic. We say it's a dual package. And though in India, we've been talking about undernutrition for a long time, for many years before, I think obesity has also taken up in a big way. We recently looked at our data from the National Family Health Survey, looking at over 600,000 patients and people, and we found that about 35 to 40% of our Indian population, adult Indian population, suffers from obesity. So when we try and understand the pathogenesis of diabetes and obesity together, what we learn is that one of the major things that stand out is the energy imbalance that happens. The energy imbalance in the form that there is much less energy expenditure and a much higher energy intake. Now, over the years, what we've learned is that this is no longer considered as just a matter of willpower of the individual. This is more biologically determined. Today, when we talk of this energy imbalance or we talk of appetite, we know that there are certain hormones in the hypothalamus that decrease our appetite. Hormones like leptin, the activation of the MC4R receptor or the POMC neurons. So all of this would decrease appetite, would cause satiety. But at the same time, there would be certain hunger hormones like ghrelin, like agouti-related peptide or NPY. And these hormones, when are high, which could be genetically determined, can cause decreased appetite. So often there could be an imbalance here. Well, this is also regulated both by the adipose tissue and by the gut. And this is also further stimulated or downregulated by environmental, behavioral, and metabolic cues. So what we see in the slide is, yes, definitely appetite is controlled, is really complex, but it's just not a simple question of willpower of the individual. Cutting a long story short, what this all amounts to in our clinical practices, we often have a patient sitting in front of in the OPD, wherein we are trying to counsel the patient, look, you have to reduce your calories, you have to reduce your food. But the patient is like, doctor, I'm hungry all the time. Doctor, bhook lagti hai har waqt, kya karna hai? So how to manage that appetite? I think that's the important question that I will try and address in this setting. And there are broadly 5 domains which can be used in clinical practice to address appetite. Yes, dietary modifications stand first. Also, we look at the literature which is available with respect to the timing of exercise, the quantum of exercise, and how do you place it along with meal, and how does that impact the appetite. We'll talk about the medications that we use for management of diabetes and how they behave with respect to appetite control. The previous lecture, we just mentioned about bariatric surgery, but that also has some impact on appetite control. And we'll also touch upon certain newer therapies which are emerging, which can target genes, which can change the appetite. So let's get started with the dietary modifications. And I think there are several guidelines which are available in clinical practice when you talk of dietary modifications in patients with diabetes. Recently, we published the South Asian Consensus along with the colleagues in Sri Lanka, Nepal, and other countries in the South Asian region. And if there was one important point that I had to bring out from this consensus paper with respect to appetite was that all of us in the South Asian region need to have adequate amount of protein. Even in India, no matter we look at North, South, West, or East Indian diets, we wouldn't be consuming the amount of protein that we should. And therefore, it becomes really, really important to advise our patients regarding that. We recently looked at our own data. This is data from the Vellore Obesity Clinic, wherein people are consuming maybe up to 150 times the calories that they have to But even after consuming so many calories, it don't make up to the protein intake. Now, this becomes really important because it's not only that we are talking of very high protein. We're just talking about the normal recommended amount of protein, maybe 1 gram per kg that we recommend to our patients. And just improving that small amount of quantum of protein has been shown time and again to improve satiety in patients with type 2 diabetes. A couple of years ago, this was, I think, over 15 years ago, we did this study wherein we just gave exactly the same calories to patients with diabetes who were on metformin, and we just changed the carbohydrate to protein ratio in their meals, and we see what is the difference. So it's not only for the appetite, but even you look at the peak of glycemic control, it is much different in people who have adequate amount of protein. So it's not only about the protein that is taken throughout the day, but even in every meal. Well, which protein is good is the next question that we need to address. And there are different types of proteins, especially if you go to the market. Yes, there are natural sources of protein, there are artificial sources of protein. But when you're talking of plant versus animal derived proteins, if you look at the literature which is available, I think more and more literature is supporting plant-based proteins as to be more promising for better satiety and better appetite control. This was a paper that we looked at for dietary changes in type 1 diabetes. Believe me, there are a lot of options even in the Indian diet. Even if our patients are vegetarian, there are options of low carb, high protein snacks that can be offered to our patients. So apart from protein, is there anything else? Does the fat really matter? And then we look at this paper which talks about the high fat diets and what is its role with respect to appetite control. If you're talking of unsaturated fatty acids, I know unsaturated fatty acids by conventional teaching is definitely better than saturated fatty acids. But what has been shown in this study, again, the amount of ghrelin suppression, ghrelin is the hunger hormone that I showed before, and using high fat diets, especially polyunsaturated fatty acids, have been shown to have a higher ghrelin suppression. Probably this is one of the reasons why keto diets suppress appetite so well. And I'm not a big fan of these diets per se because these aren't really long-term sustainable, but this is probably the mechanism of how these diets actually suppress appetite. It's not only the ketogenic diet, even intermittent fasting has been shown to reduce the ghrelin levels, the hunger hormones, and thereby increase the tendency of fullness in our patients. So ultimately, cutting a long story short, when we talk of dietary changes in patients with diabetes, where we want to control appetite, I think the most important message that stands out is to improve the protein content not only throughout the day, but through each meal, to make sure that we are able to provide more vegetarian-based protein that is probably better. And if you're looking at fat, probably polyunsaturated fatty acid has a better control. Both intermittent fasting and keto diets work by reducing ghrelin and reducing appetite. Let's talk of exercise. And that's the next important thing that we often talk to our patients in our practice when we are managing patients with diabetes. So what does the literature tell us with respect to exercise and appetite control? So early morning timing. So early morning walks are probably the better timing to reduce appetite. What about in relation to meal? This was another interesting study where they looked at whether exercising 180 minutes before meal or exercising 60 minutes before meal would provide you more fullness and satiety. And what has been shown is that it should be done maybe just within an hour of meal. A 30-minute exercise is probably better to produce satiety rather than walking 180 minutes before, and then you would be so hungry at the end of it that you'd probably end up eating much. So again, both the timing and important relationship with respect to the meal timing is important. So early morning and immediately before meals may be a better timing rather than a long gap between exercise and meal. What about medications? And we are all aware that there's so many medicines for managing diabetes. Our knowledge of diabetes medications have improved from a traditional triad to only a soft date, and there are umpteen number of medicines. But if there was one category that I would pick up, and that would be obviously GLP-1 RAs. In this slide, in this paper, we published the importance of not only the A1C reduction, but also the weight reduction that happens with each of these GLP-1 RAs. And when we look at the drug, I think the one that really stands out with respect to both weight reduction and A1C reduction, it would be semaglutide. It's been the talk of the town. We look at the impact of oral semaglutide on appetite. The study, it's very clearly shown us that it does have a major impact on appetite, and it reduces the calorie intake significantly, both in the lunchtime as well as in the evening meals in patients with diabetes. So yes, and that's probably the reason why it has about 15% weight loss, as was shown in this classic NEJM paper at 68 weeks. So yes, both oral and subcutaneous semaglutide tend to help us with appetite. Obviously, the subcutaneous one is far more potent with respect to the appetite reduction and obesity management. Well, the future of anti-diabetes and anti-obesity medication is again very friendly with respect to appetite. Both drugs like tirzepatide and cagrilintide seem to have very good appetite reduction. Cagrilintide, the amount of weight loss that we see in the phase 2 trials today, is almost equal to bariatric surgery. So if this drug really comes through the market, I think it would be a game changer again in our clinical practice. There are several other medicines, and for interest of time, I'll move on. So yes, we've talked about dietary modifications. We've talked of exercise with respect to its timing in relation to the meal, timing in relation to the day when we have to do it. We've talked about medications that help to control appetite. What about bariatric surgery? I would say that's the king of obesity management in patients with diabetes. Yes, there are specific indications in this paper. This entire edition, which was published in March 2020, it's dedicated to surgery and appetite control. I think we all are well aware that after bariatric surgery, the appetite comes down significantly. It's because of high fat cravings, the sweet cravings, everything comes down. And that's definitely because of all these hunger hormones like ghrelin, which comes down, and that reduces appetite. So I think there's no doubt about it. Enough and more evidence is available, both with respect to the cravings for energy-dense foods, as well as the preference for these foods. What about intra-gastric balloon? And this is something that we've been doing in Vellore now for over a year or so. We've had good results. Again, this is shown to reduce appetite, but this doesn't reduce appetite, but reducing the hormone. So in these two studies where they've looked at intragastric balloon and the impact on appetite hormones, ghrelin, it doesn't really change much. So probably in intragastric balloon, it's more of the physical position or the fullness of the stomach, which is more important. It's not really a central mechanism, unlike where in bariatric surgery, the ghrelin comes down significantly. And my last part of the talk is the newer avenues with respect to targeting genes. And I think I did speak about the different genes that are helpful in regulating appetite, whether it's the POMC, leptin, or MC4R pathways which are affected. But why is it important for us, especially as South Asians? We see that, in especially in Tamil Nadu and Andhra Pradesh, there is still significant amount of consanguinity that we get to see in our country. And when there is consanguinity, there are more genetic problems. In this paper, when we looked at the utility of genetic testing in people with morbid obesity, we found that a significant proportion has it. But why am I talking so much about it today is because today we have drugs. We have drugs which can target these genes in those patients and can produce remarkable weight loss to the scale of 30 to 40 kgs if you have a patient who's got one of these mutations. In our study that we did here in Vellore, we find that about 16% of people with young onset obesity have these mutations. And so again, we need to be opened up to doing these kind of testing. Similar data available from other centers. This paper from Pakistan, as high as 30% of children with young onset obesity have these kind of mutations. So when do we ask for these genetic tests? When we have a patient who is having obesity, which is less than 10 years of age, with morbid obesity, consanguinity, and associated with other associations of young onset obesity. So I think with this, I come to an end. And to conclude, what I would say is that there are several factors that impact appetite regulation. Yes, dietary factors are important. We talked about altering protein. We talked about altering fat. We talked of the role of both intermittent fasting and keto diets, how it affects the appetite. Exercise is important, both in terms of the timing of exercise in the day as well as the meal exercise gap. We talked about the newer drugs which are available or likely to be available shortly, and how they can curb appetite very well. We talked about both bariatric surgery and intragastric devices. Both work totally differently, but are helpful for weight loss in people with diabetes. And last but not least, the emerging role of genetic testing, especially now because there are specific therapies which are becoming available for treatment of these disorders. So I'd like to thank and stop here and be happy to take any questions. I'd like to acknowledge the obesity clinic team here at CMC Valo. Thank you.